Welcome back, everybody, to another episode of the Psych Guys podcast. Thank you so much for joining us, and for those of you guys checking us out for the very first time today, I'm Dr. Joon Chun. This beautiful man right here, he's my co-host, Dr. Logan Noone, and we are both psychiatry residents. Logan, what do you have today?
All right, beautiful introduction. Thank you for the nice compliment on this gorgeous May Wednesday evening. We're going to be talking about insomnia in pregnancy. Really why we're talking about this today is I was assigned this journal article that I'll get into as part of my assignment as a psychiatry resident. Reminder to the listener, we are both psychiatry residents, graduated from medical school, but still not psychiatrists yet.
Dr. Noone putting in that academic work.
Boom.
Let's go.
Yeah, so, I actually learned a lot more in this project than I anticipated. We're going to be getting into the weeds, but also trying to keep it at a level that could be consumed by really anyone, even if they're not necessarily in the medical field. But, I want to make this episode, if you have a loved one that is pregnant and dealing with insomnia, I hope that this information can help because, it's a real problem. And there's pregnant women out there suffering. And, I really feel so compelled as a psychiatrist to offer assistance. There's improved outcomes for babies when the mothers sleep better. But, we don't always achieve that goal perfectly. Giving a mother medicine, yes, maybe you might be able to cure their insomnia, but then maybe you create other issues down the line too. So we'll talk about all that. All right, so kind of this presentation, we're going to talk about the prevalence of insomnia in pregnancy, the damage of insomnia, really kind of the current guidelines of treating insomnia, and then considerations of what do we do when we have that pregnant patient that just cannot sleep a lick.
All right, Logan, before you go any further, for the listeners who may not be in the medical field, we got to start by defining what insomnia is.
Yes, sir.
Please explain. Teach us.
Yes, sir. Okay, so insomnia is defined as the difficulty initiating or maintaining sleep. And I think that's super important for people to realize. It's not mutually exclusive. You can, of course, have a little bit of both. But for us psychiatrists, we should try targeting one or the other in a sense. So if you have a difficult time falling asleep, there's a certain set of drugs, a certain set of techniques. Difficulty maintaining sleep, there are other drugs that try to keep people asleep throughout the night. Also a definition of insomnia is someone who's waking from sleep too early or the complaint of non-restorative sleep. So, there's a lot of people, a lot of women, a lot of pregnant patients who deal with sleep disturbances during pregnancy. One study reported that between 66 to 94% of women reported some kind of sleep disturbance during their pregnancy. And you know what? It kind of gets worse with trimesters, unfortunately. Mm-hmm. So in the first trimester, sleep actually increases a little bit, interestingly. So the average for these patients, they increase up to roughly 7.5 to 8 hours of sleep. So seems like relatively adequate sleep. Remember that's an average. So right. Not all women are dealing with that.
How many hours did you say, Logan?
7.4 to 8.2.
8.2. So that's pretty good.
Right. What you should probably be getting, right? But then, by the time that third trimester comes around, that average of sleep decreases to about 6.6 hours to 7.8 hours. Remember, that's an average too. So there are people on kind of the extremes. And what we're really having this conversation about is the people on the lower end of that extreme that are getting really minimal, poor quality sleep.
Right. So Logan, when you say good sleep, bad sleep, poor sleep, how do we actually quantify the quality of sleep? What exactly are we looking at? Is it just purely the number of hours that somebody's sleeping? Because in terms of the hours, I know the usual, the National Sleep Society recommends 7 to 9 hours for an average adult. But what are some of the other factors that go into quantifying what good sleep really is?
Right. So it has, at least in this study, and there's many different studies trying to define that exact answer, because it's more than just a number. Some of our patients who deal with depression deal with hypersomnia, right? Sleeping too much, but they still don't feel restored the next day. They don't have an energy level that they feel adequate with and proud of, right? So that was actually a component of this study, and this study was out of a OBGYN journal, so something a little outside of my realm, but kind of talking about how prevalent insomnia is within pregnant patients especially. And in this study, of course, they were looking at the number, how many hours of sleep someone was getting, but also the sleep quality, and how they, subjectively quantified that is they asked these patients, do you feel restored the next day? Do you have enough energy to do the activities of your daily life?
Okay. So I feel like already, if I can make one criticism against this study, is that those kind of definitions for good sleep and bad sleep can be kind of subjective,
100%.
right? Everybody has a different sense of, what an adequate level of energy is for them to complete their daily tasks. So, I mean, but no study is perfect. There's all sorts of problems with all different tests and studies out there. So carry on.
Right. So there are big differences in the quality and quantity of sleep as a woman progresses through their pregnancy. In the first trimester, roughly 13% of patients report dealing with some kind of sleep disturbance. Second semester, that's increasing up to 19%. But by the third trimester, there is 66% of patients dealing with some kind of sleep disturbance in that third trimester, all the way up until birth. So almost 75% of women display some kind of degree of insomnia at 39 weeks. So right before they're about to have birth, there's a very good chance that they're dealing with some kind of insomnia. And, as many as 15% of those people reported as pretty moderate. So why is this happening? That's one thing I really hated studying OBGYN in medical school. I thought it was so utterly confusing, really intimidating. And of course, I always knew that I wanted to be a psychiatrist. So I found this really interesting. In the first trimester, why a woman is getting worse sleep potentially as they're dealing with nausea and vomiting issues, as well as urinary frequency and then possibly backache. I guess it kind of makes sense. You do have something growing in you, pushing on the bladder, pushing on the stomach, causing kind of some of these changes in your gastro tract, acid reflux, potentially all of these things. So that kind of made sense. But it also, remember the numbers I was talking about earlier, 13% of patients report sleep disturbance in the first trimester. So, it's not a ton of people, as much as compared to the second and third trimester. That fetus starts good old dancing, good old kicking, trying to move around a little bit. A lot more women at that stage are reporting symptoms of heartburn, cramping in or tingling in their legs, or even shortness of breath, and that ends up waking them up, causing a poor night of sleep.
Logan, I'm hearing you explain this, and the question that pops up into my mind is, first and foremost, why is sleep so important? I mean, obviously, we know when we talk about it on a very superficial level, it's important to feel alert the next day. It's important to feel, not groggy, have, just that emotional health that a good night's sleep can restore for you so that you can carry on about your day. And, we were former medical students, right? Now residents, we're still continuing our education. So for me, one of the biggest benefits to sleep that I think about is the effect on learning. Right? Sleep is a big component of memory consolidation and in turn learning and really retaining the information that you're seeing day in, day out. But I'm wondering, Logan, for a pregnant patient, is there any other kind of benefits in addition to all those things that we generally, us non-pregnant folks generally experience? Is there anything special, if for pregnant patients?
Right. Well, honestly, I don't really know specifically for that question. Thinking about relevant to what you're talking about, learning and focus. Man, if there's a pregnant patient out there who is also in the midst of going through school, man, my hat's off to you. That is one badass woman, and that is pretty cool and inspiring. But I think it makes total sense. And, I certainly didn't dive into the specifics, how it applies to learning. But I think one of the best ways to understand your question, like what does quality sleep give us, is looking at the consequences of when you don't get that quality sleep. There's a pretty clear understanding that sleep loss is associated with increased cardiovascular risk and mortality. In short, this is kind of a study that I pulled out from the American Academy of Sleep Medicine. But really what it was understanding is looking at the general population, and people that don't sleep well, they die sooner. They end up getting either strokes or heart attacks, cardiovascular disease. It's also possible, kind of maybe what you're referring to earlier, that, a lack of sleep does lead to an increased amount of stress hormones. So when we think about our pregnant patient, that pregnant patient who's not sleeping at all, those stress hormones, that cortisol is getting released into that fetus, and it could trigger gestational diabetes, hypertension issues. There's also pro-inflammatory issues. This one study was looking at pregnant patients as well as general population, or excuse me, this was actually just for the general population. So sorry. But when people were not achieving good sleep, suffering from insomnia, there was an increase in really all of the inflammatory markers that we see in a regular blood panel. Routinely me and you will get something called a CRP, C-reactive protein, and we see that elevated. And of course, it's not perfectly true, but it's likely that they're dealing with some kind of inflammation, as well as interleukin 6. That's another common one. I don't consider myself an immunologist. I'm definitely getting outside a little bit of my lane here, but it is thought that a lot of mental health issues are possibly even related to some kind of inflammation process. Okay, so what else? When a pregnant patient is not achieving good sleep, she's more likely to get gestational diabetes. Could be a condition that she lives with just in that pregnancy period, or it could, of course, progress to normal diabetes afterwards. So, each loss of hour of sleep is associated with a 4% increase in glucose, and patients who slept less than 6 hours per night early in pregnancy was associated with an increased third trimester blood pressure. Lastly, kind of what you were talking about, not so much the learning, but really the mental health factors of this. When patients are not sleeping enough, it is a risk factor for developing depression. Kind of talked about this earlier, right? But is it the chicken or the egg? Is it because you're depressed, you're not sleeping? Or is it because you're not sleeping, you feel depressed? A little bit of both, who really knows? One of the SIGI caps, and what I'm referring to, the symptoms of good old major depression disorder, is sleep issues, either hyper or hypo amount of sleep. Lastly, less than 6 hours of sleep compared to the colleagues, the other patients, pregnant patients that is, who are sleeping more than 7 hours. So those patients who slept less than 6 hours were more likely to have longer labors, 4.5 times increase in C-sections, and more spontaneous preterm deliveries. Reduced sleep actually even was suggested to be associated with an increase in the patient's perceptions of pain throughout labor. Because when I was first studying this, it's like, I don't want to use drugs in my pregnant patients. I'm really scared of the damage it could potentially hurt the fetus. But, insomnia can do a ton of damage to both the fetus and the mother alike.
All right, Logan, let me jump in. So you said something very interesting before you looked into this issue. You said that you didn't really want to prescribe medications for sleep for your patients, right? And you certainly mentioned, the potential danger to the fetus as, these medications can cross that placenta barrier. But what other reservations did you have in feeling that sort of way?
Right. I mean, I think I have a certain bias against benzos. I think physicians, nurse practitioners, PAs in our general generation, I imagine, have a similar bias where we've seen the damage of benzodiazepines. And these are the drugs we're going to talk about. Benzodiazepines can be extremely addictive. It's easy to overdose on a benzodiazepine in some regard. So I've heard actually an ED physician say it's not if you can get him into an into a ventilator, pretty quickly. If you don't have your series of benzodiazepines and you abruptly stop, you can get thrown into a seizure. So for a whole multitude of reasons, it's like, yeah, no, I don't want to do that. It's like I can just start feeding into this person's potential addiction issues in the future or just complications in the future. So I acknowledge that I have that bias. Do you think you share that same attitude?
I don't know if I will phrase it as a bias, but maybe we can phrase it as a concern, because what's more common than a psychiatrist hearing about a patient's sleep issue, right? I feel like this is something, regardless of the setting that we're treating patients in, this is an issue that comes up constantly. Doctor, I can't sleep. Can you do something for me? Right. And most of the times, you are very, very hesitant to go the route of benzodiazepines. And one of the things that you left out in terms of the long-term harmful consequences is that benzodiazepines is one of the few drugs that you can actually die from if you withdraw from it.
Yeah.
Yeah, it's very dangerous. And long-term use can lead to cognitive decline as well. So especially when it's a young patient, as in, patients that are of childbearing age, I'm even more hesitant. But to be honest, it's not given the levels of danger, it's not a medication I feel very comfortable prescribing. And, besides the inherent dangers of that medication, I also question how much is the benzodiazepine really doing for that patient? So,
Right.
for example, they've done sleep studies on this. They've looked at patients, placebo versus putting patients on a hypnotic sedative, right? These benzodiazepines, the Z drugs, they're considered sedative hypnotics, right? Because what does it actually do? In your brain, it's hitting the same receptors that alcohol is essentially
Right.
hitting. So it's basically alcohol in a pill form. And what happens when you drink too much alcohol? You start to get a little bit woozy,
Right.
and you can pass out, go to sleep, right? So there's a clear distinction when you look at sleep studies that show that real sleep and benzodiazepine induced sleep, there's a difference in the brain waves that are measured. So for example, when you look at patients that fall asleep after taking sleep medication, they're missing the deep delta waves on the sleep studies. And that's stage, N3 and 4. We can get into the details of sleep.
Right.
But, long story short, those are the most important components of sleep for you to get a full night of restorative sleep. But at the same time, when you ask these participants, they can't differentiate between the real quality restorative sleep of naturally induced sleep and then comparing that to the benzodiazepine induced sleep. So people mistakenly believe that they're getting restful sleep, but at the same time, when you look at the sleep studies, the quality of the sleep is vastly different. And that's why when patients take these medications, a lot of the times they'll come to us and they'll say, "Hey doc, I feel super groggy in the morning. I still feel a little bit woozy." Right? And then what happens in that circumstance? They'll usually reach for an extra cup of coffee.
Right.
They'll be more tired in the afternoon.
Let's hope it's coffee.
Yeah. Or whatever else they're using.
Right.
They're going to reach for a stimulus, something to give them a kickstart. And in turn, that night, because of the residual effects of the caffeine or whatever substance that they're taking, they have even more of a trouble falling asleep. And what do? They take more drugs to help fall asleep. And it becomes this perpetual cycle that leads to a downward spiral.
Right.
That's my concern, my biggest concern.
I think that was, beautifully said. And, actually, I'd really like to, in future episodes, get into the nitty gritty of sleep, getting into the different sort of electro waves that we can measure with sleep. Why I think I used the word bias earlier is I've seen, I don't need to say the number, but more than enough of pregnant mothers who come in addicted to many different substances. Their fetus is exposed to many different those substances, and at least about outcomes. It's tough to see. It's cases like that I find most challenging in this career, regardless of if it's in the mental health industry, right? Anyone who's in the healthcare industry touches these cases in some regard. These are the cases that I feel like that keep you up at night, that you think about when you're talking to your wife at dinner or when you're even playing video games, a time where your mind should be clear. I think that's some of the most challenging aspects of this career that we've chosen, working in healthcare, is those tough cases where you have that mother that is dealing with some substance use issues. Maybe they don't want to necessarily harm themselves or the fetus, but they're not able to stop that substance use. So that's my bias towards even using a lot of these medicines, because I don't want to feed into this at all. I want to try to teach these patients, to the best of my ability, of course, to use. We're going to even talk a little bit about cognitive behavioral therapy for insomnia, other healthy modalities. A lot of this conversation today is going to focus around the drugs, whether to use or not use it. But, as much as we can, try to encourage these patients to use non-pharmacological methods to try to improve their sleep.
Right. And I think that's part of the reason why we're having this discussion today. There's nuances to whether or not we should be prescribing medications to help people, especially those that are pregnant, help them sleep, right? There's clear risks associated with insomnia, clear risks associated with a lack of sleep for the patient themselves and even for the baby going forward, that can even last a lifetime. But at the same time, I think we just acknowledge that there are clear concerns and dangers associated with the medications themselves.
Right.
And I think this is why there's not a single, one size fits all approach to medicine, right? Each and every patient's situation, circumstances are different, and they come from different backgrounds. They may even respond to medications differently. And as clinicians, I think that's a big part of what we do. We're really aiming to provide that individualized care that's unique to each and every person's circumstance.
Right. So, today, let's not talk too much about cognitive behavioral therapy, but there are wonderful YouTube videos. So, if you're someone who's suffering from insomnia, I would encourage you to check out 5-minute meditation, CBT guided exercise for insomnia. But in short, kind of CBT is trying to identify behaviors, feelings, and thoughts and trying to break their cycle. I've dealt with a lot of insomnia issues in my life. I think it's a symptom of my bipolar disorder. I remember when I lived in Scotland at that time, I was dealing with some jet lag that just ended up turning into a chronic insomnia issue. And I was getting like 2 hours of sleep at night. And then I would spend all day ruminating, thinking about how much sleep I would get that night.
How long did that go on for? Is that just like jet lag?
That went on for 8 months.
For 8 months, dude. I didn't even know you lived in Scotland. What were you doing out there?
Man, you clearly are not enough of a stalker, Joon. You got to step your game up. That was a study abroad program. Also learned to really develop a passion of and love and appreciation for golf. Golf at that time in my life was my medication for my bipolar disease. It was in St. Andrews, Scotland, the home of golf. An amazing, wonderful place. Going back to what we were talking about, though, I was dealing with significant insomnia. Basically the prodromal aspects of my bipolar disease at that time of my life. Of course, I didn't know that. Of course, I was trying to, self-medicate in certain ways as not any, but 19, 20-year-old people do. And I would spend all day ruminating of how much sleep am I going to get tonight? That was all I could think about, just ruminating. And then, night would come and I would find myself looking at the clock and, if I fall asleep at this exact moment, I will get 8 hours of sleep. Oh shit, now it's 2 a.m. Okay, if I fall asleep at this exact moment, I will get 6 hours of sleep. Exactly. Your brain doesn't work like that. A lot of the recommendations involve, not actually having a clock around your area. There's certain sleep hygiene methods that I'm sure our audience is aware of, screen time, not exercising within 2 hours of going to sleep, engaging in relaxation methods. What else am I missing here?
Waking up at the same time every day,
Right.
regardless of the weekend. And the exercise thing is very interesting because exercising within a few hours of bedtime can be detrimental to getting good sleep, but exercise earlier in the day is actually really beneficial for your sleep. So you got to make sure that you do it at the right time of the day.
What I found really helpful, and I encourage all of the listeners to check out, is good old Andrew Huberman. He's been on, I feel like,
everywhere. Everywhere.
His popularity has gone up insane in the last few years, but the whole trying to get sun exposure within the first 2 hours of the day, not using your sunglasses the first 2 hours of the day when you get up, not consuming caffeine within the first 2 hours of when you get up, and trying to use the natural ability of the sun to almost wake yourself up. I've been applying that to my life. I am by no means a neuroscientist, and I don't feel comfortable getting into the nitty-gritty of that. Go check out Andrew Huberman's stuff. But from an anecdotal perspective, I've been trying to apply this to my life. It's been helping very much.
All right, but Logan, how well does those kind of tips go over with your patients? When you have that patient that comes in, they're like, "Hey doc, I'm struggling with sleep. I've done everything." I feel like they immediately, the sense that you get is they're not trying to hear that stuff.
Exactly.
They're not trying to hear like, "Hey, don't have an alarm clock.
Don't you know I'm a yogi?" Yeah.
Exactly. They're not trying to hear it.
Right.
So in that situation, first of all, how do you feel in that situation? Do you feel some sort of discomfort? Because I certainly feel a little bit out of my element because that's what I want to say. But there's that mismatch, right? I feel like there's an expectation that the patient wants to hear something different. How do you feel in that situation and how do you handle those situations, Logan?
I think it's very important that I at least I try my best to point out with these patients and these sleep medications that, look, I've prescribed most of these that we're going to talk about in some regard. Look, in an acute situations requires acute solutions. When you're really, really suffering is when we need to be the most aggressive and really need to help you to the best of our abilities. So when I've been that patient in a hospital bed, right? And I'm sure you've had moments of your life too. It's a weird place to be. And how can you really achieve amazing good sleep in a hospital bed? Well, I say that, the vast majority of our experiences have been inpatient. But, when you're at home, I think about like, let's say you just moved to a new place or you just suffered some significant trauma in your life where perhaps maybe you were assaulted at night. And when it's nighttime, you get triggered and significant PTSD potential, or I guess at that point, acute stress symptoms. Come on. Those are acute situations where I feel very compelled as a soon to be psychiatrist, almost there, but a physician able to prescribe these medications are, well, look, let's do a short course of something like this to kickstart your sleep habits.
Right, I agree. In the short term, I feel like sleep medications are a great option. I mean, we all go through tough stretches where we may need a little extra help from something, right? But I think for long-term use, I'm very hesitant to prescribe or even recommend sleep medications. And I think even the manufacturers do state that these medications were not intended for long-term use.
Right, exactly. So let's kind of get into the actual guidelines of what the American Academy of Sleep Medicine clinical guidelines suggests, and that's kind of what I base a lot of my recommendations off today. So I'll put this up in our show notes. I don't need to get too into the nitty gritty of all this because I know not all the listeners are someone who can prescribe or necessarily wants to take medicine. But, it's important to remember breaking up. Are we talking about sleep onset insomnia or sleep maintenance insomnia? Because there's differences. The Z drugs, the ones like the Ambiens, I was trying to look up the name of I'll say the generics, but I have a hard time saying that. The S-zolpidogrone. Do you know how to say that one?
You just keep going.
Just let me fucking try. Leave me out. The Zolpidone. I can barely say these animals.
Zolpidem. That's how I say it. I don't even know if I'm saying it right.
I mean,
yeah.
That's Ambien that most people know. These can help with sleep onset insomnia. There's just some benzodiazepines, Ramelteon. Thank God that one's easier to say. This can help with sleep onset insomnia. And what I think is important here is, some of these drugs can help with sleep onset, but they don't always necessarily radically improve what we call sleep latencies or the ability to kind of get to sleep. Some of them can reduce it by up to 37 minutes, but some are only, 5 to 10 minutes. Ambien, can have effects, but it's not having a wild effect necessarily.
So Logan, given, that there are inherent risks with any medication, for that matter of fact, a 30-minute increase in your ability to fall asleep faster. I mean, I feel like that's not very significant. How do you feel about that, Logan?
I mean, remember, these are all averages again, right?
Sure.
So it's like, yes, the average is 30 minutes. There's a possibility it's not going to do anything, or maybe even, 2-3 minutes. But there might be that patient that is able to get a higher quality of sleep. These drugs, though, remember, we're talking about sleep onset insomnia.
Right.
So the ability to fall asleep, not just necessarily stay asleep.
Okay. And I want to add something on there to the fact that, what you just said about there's a possibility that it may not even be doing anything.
Mm-hmm.
So there was actually a meta-analysis of 65 studies consisting over 4,500 patients. And they took both placebo and sleeping pills. And it showed that both of them reduced the amount of time it took for participants to fall asleep by 10 to 30 minutes. And the change between the two, placebo versus the medications, was not statistically significant.
Wow.
So, I mean, but we have to recognize that placebo effect applies to all different medications, right? So there is a question about whether or not these things, like you said, really are doing anything.
Mm-hmm.
But, the way I look at it is, hey, sometimes the situation is that dire. And this is the best that science has to offer to us right now. And, we can only do what medicine teaches us to do, right? We wish that we could do more. We wish we can change lives for patients. But the reality is that we're limited in our capacity. And unfortunately, this is the best that we've got. And sometimes we just need to work with what we have.
Perhaps. I would also say that one thing that actually frustrates me in some regard is, science has accepted that placebo is a real thing.
Right.
So why can't us physicians actually prescribe a placebo? Especially for that patient who is pregnant, who we're super scared about starting medicine because we know it can have actually impacts.
Hold on, Logan. Hold on.
I will argue it.
Hold on. So are you suggesting that when a patient comes to you, let's say a pregnant lady in her 30s, right? And she's saying she has a difficult time sleeping. And you're like, I got you. I got the perfect medication to help you out.
Right.
And you're going to go to your back office, fill that with sugar, just pack it up and then give it to her?
Look, I think that there's a time and a place, right? Especially, think about this. What if the person's symptoms were mild? Why am I compelled to treat someone who's dealing with maybe mild insomnia? What if that is someone who does have, anxiety issues just around their health at baseline? I think of the tenets of being a physician, right? Do no harm. I think where the harm would be is if I charge them for that medicine that is clearly just placebo. I know it's a placebo, but I'm at least trying the act of giving a patient something. Now, look, I don't love that. I wish we weren't in a society that likes immediate gratification, that in a sense kind of feeds into this model of taking a pill to treat something. But I would argue, why aren't we then trying in some situations the least harmful thing? It isn't the least harmful thing, maybe placebo, and we know placebo can work.
I see what you're saying, Logan. I hope if you ever actually do decide to do that, you put those pills in an Ambien box.
Right.
You go all the way if you're gonna do it.
Then I think that's unethical. But okay, so we are using the words Ambien. Remember, that is the trade name for Zolpidem. And so now going back to some of those drugs that, please feel free to laugh at me because I'm a physician, I'm a doctor, and I can barely frickin' say these things. Zolpidem is Lunesta. Lunesta, you've seen probably commercials. Zanata is Zalpilan. I don't know. These drugs, at least though, have been indicated potentially to maybe help out with both actually. Lunesta is sleep maintenance as well as sleep onset. The Ambiens is probably helping a little bit more with the sleep onset, but there is kind of like a delayed release formulary of that Ambien that maybe can help out a little bit. One of the drugs, though, that I actually very rarely use, I've actually even heard old school attendings say we shouldn't use it, but now this kind of new recommendation that, this is a big journal released in 2017, said that doxepin, an old school drug, not necessarily being used to help out with depression, can actually help out with sleep maintenance. When this drug is used at 3 milligrams or 6 milligrams, the mean improvement of sleep maintenance was 26 to 32 minutes longer. What do you think about that?
I think that's great. The more options that we have, the better. But I think doxepin still carries some of the concerns that I mentioned earlier, that it doesn't induce natural sleep. Because when we utilize doxepin for its sleeping properties, I mean, we're essentially tapping into the sedative properties. We're sedating somebody to sleep. But if I had to choose between doxepin and maybe like a benzodiazepine, hey, at least with the doxepin, I'm not going to get somebody addicted. And there's no concerns that they might start to withdraw and potentially have a life-threatening situation.
Right. And
so I think it's a better place to start.
I wish also, me and you and the other aspects of the medical community could always say these things with 100% certainty. This drug is for sure safe in pregnancy. This drug is for sure not safe in pregnancy. We can make educated guesses based off observational studies, but there has been very limited amount of data in this community because it is unethical in a sense to, treat pregnant patients. What mothers are really going to sign up for those studies? There's not a ton of our favorite, double-blinded, randomized controlled trials of this stuff. I'm going to talk about a lot of the kind of the selection bias then what that leads to of observational studies. And what I mean by that is what pregnant patients are the ones that are willing to actually take this medicine when they deal with insomnia. I would argue it's the patients that are arguably maybe the least healthy at baseline. So maybe it's unfair to extrapolate things about these medicines because these medicines weren't necessarily used in the most healthy individuals, right? Like a mother isn't going to necessarily, or a soon-to-be mother, be like, yeah, give me all that Ambien, and they're sleeping fine. Hopefully not.
Well, I feel like most mothers won't, but we both know that some mothers
I
will.
mean, look, I guess that
You spend
everywhere
enough time in the hospital, you
Yeah.
know there's a handful of those patients.
you see some things. Now, look, what also I think is very interesting is, there are drugs that I've seen prescribed regularly throughout our hospital. I've even used these things at times because, there's, of course, data is not always perfectly agreed upon in the scientific community, right? I'm reading you off recommendations by the American Academy of Sleep Medicine, an organization that I really respect. But, it basically said that these medicines that are over the counter are not recommended for treating either sleep onset or maintenance insomnia. Let's talk about the first one, denphenhydramine, Benadryl. Okay, so we were looking at Benadryl doses of 50 milligrams, pretty regular dose. You could buy this over the counter, so 50 milligrams. It helped with sleep latency by reducing that by a whopping 8 minutes. Okay?
Disappointing.
Right. Improved total sleep time by 12 minutes. Okay? So, there's a 95% confidence interval that, it led to roughly, it wasn't necessarily perfect, 13 minutes to 38 minutes. But, the quality of sleep said no real improvement in quality of sleep. Next drug, melatonin, reduced sleep latency by good old 9 minutes. Quality of sleep was small. It was looking at a relatively low dose of melatonin. This study was actually only looking at 2 milligrams. I've seen patients take as high as, what's the highest you've seen? 12? I've seen definitely 10.
12, yes, I see that a lot.
Right.
Melatonin is the one thing that really confuses me. I feel like if there's ever a placebo effect with anything, it's got to be with melatonin. Because the way that melatonin naturally works and functions in your brain is it doesn't induce sleep. All it does is it signals to your brain that it's time to sleep. So if you can kind of imagine, if you're running a race, right, the role of melatonin is that guy at the start line that kind of fires the gun and says, go. Right. It does nothing to actually induce sleep. It just signals to your body that, hey, it's time to fall asleep. So if you take melatonin, you can synthetically induce that timer to go off, but the other mechanisms in your body that naturally actually help you to fall asleep aren't really necessarily being activated at the same time. So we talked about Matthew Walker last time, the guru on sleep. I read in his book that melatonin can be helpful in stuff like jet lag, where that timing mechanism is really thrown off. But for any other type of insomnia, there doesn't seem to be much clinical evidence based on it. But at the same time, we've seen that patients love melatonin. A lot of our patients certainly ask for it. They're on it on a standing basis, and it seems to be helping them. So placebo effect? Possibly.
Yeah, I mean, maybe yes, maybe no. I get really frustrated because I've seen, even in the hospital setting, the dumb use of melatonin. My understanding is it at least takes, a little bit of time, and it is a little big part of the timing mechanism. So if you are going to use melatonin to try to gain meaningful sleep, it needs to be taken within an hour, 2, 3 hours of when you want to ideally go to sleep. So what I advise my patients a lot is, hey, you're trying to go to bed at 10. You should probably take your dose of melatonin if you want to try it, maybe around 7 p.m. or so, roughly. And I'll see sometimes these melatonin PRN orders, they give it to the patient at 3 a.m. It's like, cool. What are we doing here?
Well, patient asked for it. Patient asked for it, right?
Right.
That's usually the story.
Now, one drug that I use very frequently, I see a lot of psychiatrists use, primary care doctors, trazodone. Trazodone led to mean reduction in sleep latency. Remember, that's the ability to actually fall asleep by 10 minutes. Okay. And then it also had patients did report difficulty waking up, after sleep onset of 8 minutes. No improvement in the quality of sleep that was reported. This was looking at a 50 milligram dose of trazodone, something we regularly use again. So that's actually one thing I found very, very surprising. I feel like that's a medicine that a lot of prescribers feel more comfortable giving for sleep as opposed to benzodiazepine or these Z drugs. Maybe it's not actually helping as much as we think.
Evidence seems to suggest that it's not doing anything.
Maybe not anything, but not enough.
Barely anything.
Not enough to, maybe the harms outweigh the benefits, right? Maybe there is some benefit. To say there's zero, I always think is unfair, but the potentially the harms outweigh the benefits, okay? So, this paper was kind of looking at this neuroscience and biobehavior reviews, basically using benzodiazepines and Z drugs in pregnant patients. Okay. So, why are we concerned about this? These drugs easily pass through the placenta and the fetal brain barrier. These bind to GABA receptors. It can potentially impact the fetal central nervous system. It's definitely plausible that this impacts fetal growth. Like, why not? It kind of makes sense from a theoretical standpoint. Does this actually make sense, though, when we look at the hard data? Maybe yes, maybe no. But there is some association between benzodiazepines and Z drugs for spontaneous miscarriage, preterm birth, C-sections, low birth weight, small head circumference, low APGAR scores, and most especially when they're used towards the end of pregnancy, right before that baby is about to pop out. Elevated risk for low muscle tone, neonatal respiratory distress, and basically the baby withdrawing. This makes sense, but I think it's very unfair to say this is purely from the drugs too, right? Like, remember, the pregnant patients that are choosing to consume these medicines are also arguably maybe some of the least healthy patients too. This is not basically a double-blinded understanding of these medicines.
So all those things sound very scary, Logan.
Absolutely.
Right. So we're about 42 minutes in. So I don't want to leave this conversation off on that scary note.
Right.
So can you just quickly remind us one more time, what are some of the benefits? Like, what is the real dangers of untreated insomnia in patients dealing with pregnancy? Because the things that you said, honestly, they terrify me. So I can't imagine what an expecting mother would feel when they hear those kind of side effects and potential risks.
Right. Great question. So, let's just kind of go over this real quick again. Consequences of insomnia in pregnant patients. And this is kind of extrapolated some of it from the general population. Increased cardiovascular disease. That means heart attacks. That means strokes. That means clots. Insomnia can trigger stress, which leads to increased amount of cortisol that can impact blood pressure not only for you, but for the fetus. Increased pro-inflammatory states can lead to adverse outcomes. And also, insomnia can lead to gestational diabetes as well as gestational hypertension. So it's kind of damned if you do, damned if you don't.
I was just about to say that, Logan. At times, it feels like in medicine, sometimes you're choosing between the lesser of the two evils.
Right. One thing I actually found interesting in this education that I did for myself is I almost assumed that these medicines led to congenital malformations. What we're actually understanding is in the last decade, there was a lot of meta-analysis with this, that they actually are not necessarily associated with the scary teratogenic effects, as maybe we once assumed.
I think this is a very good barometer, and this is how I kind of gauge my honest perspective towards the medication. If this was your wife, pregnant with your child, and she was dealing with insomnia, she's taken CBT for insomnia, does not work.
Mm-hmm.
Are you taking her to your physician and saying, hey, I think she needs to be on a benzodiazepine?
I don't like to make that decision because I think what I want to do with my patients is shared decision making. They need to understand the risks and benefits. There, of course, is benefits of getting good quality sleep. There are risks of when you're dealing with significant insomnia, both for you and for your, soon-to-be baby, but the fetus growing inside of you. There are risks to using benzodiazepines and these Z drugs we're talking about. Cognitive development, it's showing that at the age of 5, there's an increased risk of lower communication skills. A drug with named clonazepam. There was an association with intellectual disability at the age 10 when compared with controls. When clonazepam was used with normal antidepressant therapy, overall decreased mental development at 2 years of age. So yeah, there's definitely some possible harms to cognitive development. These are, remember, observational. We can't make insane conclusions, but you're right, it's scary. There's even some concerns with emotional development. Benzodiazepines has been shown to increase anxiety and internalizing behavior in children ages 1.5 to 3. There's concern of possible behavioral development. The data was a little mixed around ADHD, aggressive behavior, but one thing that did kind of stand out is exposure to benzodiazepines in late pregnancy was associated with an increased risk of ADHD. It wasn't seen as much with these drugs that were used throughout the entire course of pregnancy. So who knows?
Starting to sound like one of those drug pharmaceutical commercials.
Right.
They tell you
At
how
the
good
end.
and great it is, and then talk to your doctor.
Right. There are implications in even motor skills development. The babies who are born with mothers who use these medicines potentially have lower gross motor skills, fine motor functions. It's the patients need to be aware of all of this. It's these medicines definitely can cause direct damage to the fetus and soon to be baby. Whether it's those medicines pass through the blood-brain barrier, messing with neurotransmitters. We've currently we of course have seen an association with, like I said, preterm birth, low birth weight, low ABCAR scores. All of this stuff leads to neurodevelopment problems. But always remember, that this study, we can't conclude everything is necessarily fact. Like I keep saying, there are confounding variables that are impacting this. The patients that are likely to use these medicines are the least healthy, arguably. They're the ones who are maybe already dealing with depression at baseline, other mental health issues. Maybe they have unstable housing, and so that's a big issue why they can't sleep. Maybe they're dealing with significant pain, so we can't always extrapolate that these medicines are the ones necessarily causing the problem. It could be a whole slew of other issues. And I think that was really my biggest takeaway from all of this is, treating insomnia is complicated. Is this because you're dealing with some other issues that maybe we can address? Things that are, of course, outside of our control as physicians, but I think something that we need to talk about. Do you live in a safe home? How's the relationship with your partner or your family or your friends? Do you have any support? How has this been progressing? How's your sleep changed as you've gone through this pregnancy process? I think part of it is also educating the mother, right? Like it's anticipated your sleep is going to get worse throughout pregnancy. What are the things we can do to try to treat this without pharmacology? And look, when things get really, really bad, I think that there are a lot of mothers out there that will agree that they don't want to use any medicine. I don't want to use any medicine. My baby's potentially going to get harmed because I'm using medicine. Yeah, but if you don't get any sleep, you're also going to potentially harm yourself and the baby too. So it has to be a shared decision, and I like to think of us as physicians as, I always use this analogy, we're the car mechanic. We understand the engine better than everybody, but you're driving the car, okay? You got to make this decision where we go with this car. I can tell you exactly how it works, how we want to adjust things and tweak things, but you're the driver. What are we doing here? And that's how I pose my decisions with my patients.
I love that, Logan. There's no clear-cut answers in medicine. Like you said, treating insomnia is a very complicated issue. Medicine at large is a very complicated issue.
Right.
I think traditionally the role of a physician, historically speaking, has been one of, hey, I know better than you. This is what you need to do it. But medicine is changing, and we're young doctors. We're trainees right now.
Right.
And the way we're being trained is exactly like you said. I see my role as more being that of somebody who's informing, somebody that's educating, somebody that's providing the cons and the pros of every single medication that's out there for any potential pathology, not just insomnia. And ultimately, it's up to that patient to make the best choice for him or her, whatever that may be. And that decision is going to look different for every single individual. And my role as a physician is to help guide that process and make sure that that decision, whatever it may be, is an informed one.
Beautifully said. Well, if you made it this far, subscribe. We really want this podcast in particular to go to anyone you know who is dealing with some kind of insomnia issues in pregnancy. I really hope this can help that patient, that person who's trying to love and support that patient. We really appreciate you guys making it this far. And one of the best ways you can do to help out this podcast is simply sharing it with someone you know who think could be of benefit. So thanks for tuning in.